Hello everyone, this is Sheikh Gomari, Group 9 of the Ninth Court, Policy Advocacy in Genetics and Genomics at Pan-African Polygenics Course Education and Research Initiative PAPERI. My stand is against the premature deployment of AI-powered genomic analysis in the African healthcare systems. I will present my position against the use of current AI-powered genomic analysis in the African healthcare due to the inherent and unmitigated risk of algorithmic bias. As an introduction, states against premature adoption. I will present the firm argument against the immediate deployment of AI-powered genomic analysis within the African healthcare systems. The central question in our group addresses: should this technology be used even if it carries the inherent risk of algorithmic bias? My position is that the speculative benefits of this technology are far outweighed by the significance and foreseeable harm that biased algorithms would cause the diverse populations of the Africa. In my presentation, I will demonstrate the current state of AI in genomics and will to the tangible patient harm, violate the core principles of medical ethics in AI, and being proposed for a context that lacks of foundational infrastructure to deploy it safely. The only responsible path forward is to prioritize foundational solutions before adopting such high-risk technologies. Defining algorithm bias in genomics and the algorithm bias is not a minor flaw, it is a fundamental failure of a system to produce fair and impartial results. It occurs when AI model produces systematically prejudiced outcomes due to the flawed assumptions or data use in its deployment. In genomics, this stems from training data that fails to capture the genetic diversity of African population. The data is overwhelmingly homogeneous. For example, as of 2019, individuals of European ancestry around 78% of all participants in genome-wide association studies, while individuals of African descent comprised less than 2%, which is very low. For African healthcare, the implication is dangerously clear. AI tools trained on this skewed data are all systematically fail when applied in African patients. This will result in fundamentally incorrect disease prediction, inappropriate, and potentially harmful treatment recommendations, which is unrecommended. As an argument, the inevitable risk of direct patient harm, the deployment of AI tools built on biased data is not theoretical risk, it is direct path to misdiagnosis, patient harm, and loss of life in clinical settings in AI, which is inaccurate predictive scores, catastrophic consequences of this AI prediction, resource limiting setting. A key application of AI in this field is use of polygenic risk scores or PRS to predict individuals' risk of various diseases. However, studies have demonstrated that the predictive accuracy of PRS for conditions like coronary artery disease is 4 times worse than individuals of African ancestry compared to those of European ancestry. This is not an isolated issue, but consistent finding across numerous complex diseases, which is very catastrophic. The second one is catastrophic consequences of resource limited systems. In this context, African countries are resource limited in their healthcare systems. A misdiagnosis is not just clinical error, it is catastrophe. It is represents a devastating waste of scarce funds, a critical delay in receiving correct life-saving treatment, and a direct and immediate threat to patient survival. As a second argument, violation of core medical and ethical principles. Beyond the physical harm, the use of biased AI fundamentally violates the principle of medical ethics and justice that are meant to protect against patients to ensure for their fair treatment, such as violation of equity, digital colonialism, and breach of trust. As a violation of equity, landmark of 2019 study in Science exposed how commercial algorithm widely used in the US to predict health risks which racially biased, systematically underestimating the health needs of black patients that due to race, implementing similar tools in Africa would replicate and amplify these inequalities, directly violating the principle of equitable care in the world. The second one, as an argument, is digital colonialism and breach of trust, forcing a flawed, biased technology development and non-representative data onto African population constitutes a form of digital colonialism, like practice not only causes harm but also undermines public trust in both medical and technological innovation itself. This erosion of trust could set back in healthcare progress and decades of represents profound violation of the principle of justice. As a third argument, the absence of infrastructure for safe deployment. The continent that is Africa currently lacks of specialized infrastructure, robust funding, and trained workforce required to validate, oversee, or correct the outputs of imported biased models and chronic underfunding. Africa is home of 17% of the world population and bears 25% of global disease burden, but it receives less than 1% global investment in research and development. Same thing, the chronic underinvestment means there is virtually no capacity to build local and biased AI models or even to perform necessary checks or biased ones imported from everywhere and elsewhere, like Europe and the first world and unsustainable strategy adapting under these conditions like building a skyscraper on a foundation of sand. It is a responsible and unsustainable strategy that is granted to fail, wasting resources and endangered such lives. And as a rebuttal, like precision medicine versus equity, proponents often argue that AI is a shortcut to precision medicine and will reduce costs and increase speed of overburdened systems. These arguments are flawed. On precision medicine, there is no shortcut to equity or a medical tool that's only precise for one population group is not precise or precision medicine. It is a discrimination totally. Providing access to flawed tool is not a progress, and on cost and then speed. AI will reduce costs and increase the speed of diagnosis and overburden systems. I said that, but this is false economy. The long-term costs associated with managing misdiagnosis, providing correct treatment, and handling inevitable litigation will far surpass any perceived initial savings. Speed is irrelevant if the diagnosis will be wrong. Potential benefits of AI are entirely conditional on having representative data, and without that representative data, any argument will be built on a dangerous premise and argues that as potential benefits of AI are entirely conditional on having representative data, I mentioned it earlier. And as a conclusion or summary, in its current state, AI-powered genomic analysis should not be deployed in African healthcare systems. The technology carries unacceptable and unmitigated risk of algorithmic bias that will cause direct patient harm, like violate fundamental ethics, ethics of medical precision and ethics of AI, and fail due to lack of local infrastructure for safe implementation. The reckless adoption of flawed technology is the wrong path. The correct ethical and sustainable path is the strategic and equitable investment of African genomic research, the creation of robust African genomic database, and the training of African scientists and data experts. Initiatives like H3 Africa are already championing this approach. We must build the foundation correctly before considering the dangerous certificate. I have this idea. These are my references, and thank you very much.